Good morning and welcome to the Tulane University School of Social Work's virtual health spot. My name is Dr. Deidre Hayes, Professor of Practice at Tulane School of Social Work. And along with me is Dr. Reginald Parquet, a clinical professor here in the school, and Carrie Mulder, our Media Outreach Coordinator. We will be your hosts this morning. Pre-COVID, the Health Spot was a monthly in-person health fair held in front of the School of Social Work. The busiest bus stop in the city is in front of our school. So we had this great idea to bring information and services to the individuals who ride the bus and use the corridor to access downtown New Orleans. The Health Spot provided STD testing, dental screenings, and assessments for substance abuse and mental illness. In addition, the Health Spot served to provide information on housing, voting, multiple services available to the community, and multiple services to the community. And although the COVID-19 issue has interrupted our in-person service delivery, we continue to try to give information to the community through the virtual health spot on relevant issues of the day. So today's topic will be the COVID vaccine and the myriad of issues surrounding it, including safety, reliability, and deployment. We will address the hard topics, such as the legitimate concerns of African Americans about the historical atrocities associated with the medical profession, the psychosocial aspects of a vaccination effort of this size, and how we decide who gets the vaccine first. How do we ensure that no one is mistreated or overlooked? The Tulane School of Social Work has assembled a group of esteemed panelists to talk about the COVID-19 vaccine and marginalized population. Active in their communities and in research, each of these knowledgeable individuals will share reliable information about their areas of expertise and address questions that we might have about those issues. We will look at infectious diseases, public health, social work, and social justice. What are the unique issues facing our community? What makes the COVID-19 vaccination different? Let's find out. Today we have Dr. Cerisi West Olatunji, Mark Allen Geary, and Dr. Griggs, community doctor, and Dr. Catherine Adrianopoulos. We're going to start our presentation off today with Dr. Cerisi Olatunji, who is an associate professor and director of the Center of Traumatic Stress Research at Xavier University of New Orleans. Welcome, Dr. Olatunji.
Hello, how are you? Good afternoon. Well, thank you so much for inviting me to participate on this panel. This is such an important topic. It's been important throughout 2020, and now we're seeing it spill into 2021, but it does look as though we have some relief in sight. What I'd like to concentrate on is the issue of transgenerational trauma. Now, this is important because we think about a term that is getting some traction right now in the news, and that is vaccine hesitancy. So there's been a lot of discussion about whether or not many people in Black and Brown communities, whether they are middle income, lower income, or looking at very affluent communities, that some of the individuals are saying that there may be some hesitancy for people of color to engage and to get the vaccine. But I like to talk about it within context. I always like to think about it as starting the conversation at the beginning and not at the middle. The middle is talking about the outcomes, the effects of certain factors. And I like to start at the beginning. So when we think about people of color, certainly here in New Orleans, we want to think about people of African descent. We want to think about many of the other indigenous communities here. We have a large Vietnamese community here, and so on. We want to think about some of the historical and social context and political context for how people are responding that relate to the uptake for the vaccine. So one of the things that we want to think about is race-related stress. This is the work that I do in my Center for Traumatic Stress here in New Orleans at Xavier University. So basically what we're talking about is the fact that there are long-term effects of the day-to-day macro and microaggressions against various people who have been culturally or socially marginalized within the system. When we look at African Americans, for example, we think about continuous traumatic stress, where we experience housing segregation, and that's experienced. We think about health disparities. We think about educational hegemony for our students. So we look at all these disproportionalities in the experience that are due to being locked out and due to laws and policies that have been put in place that are designed to marginalize and position people in particular. What we saw in 2020 that relates to that is what I call the triple pandemic. And it's really talking about issues around environmental injustice. When we look at climate change and we think about who are the people who are disproportionately impacted by that, we're talking about Black and brown people. Think about police brutality that was very much highlighted last year. And we think about that in terms of specifically about Black people. And then, of course, the disproportionate rates and fatalities due to coronavirus 19. Those are very serious issues that contextualize people's responses to the idea of a vaccine. Now, people often ask, what does something that happened 400 years ago have to do with today? The problem is that we have historical memory, we have people's responses, and we know from trauma research that a lot of times our trauma responses are encoded, for example. So we know that the responses to the racism that we've experienced is something that gets passed on from generation to generation. So there are, anticipatory fears that people have, anticipatory anxiety that people have in certain circumstances where we know historically it has had negative outcomes for Black people, for example, brown people, indigenous people, and so on. And then you get on top of that, the day-to-day aggressions that are occurring, police brutality, for example, as one, but in all other sectors of our day-to-day living is something that we need to take into account. What we know from research related to chronic stress or race-related stress, traumatic stress that I do, for example, is that there are outcomes of this. There are these health disparities. So when we talk about health disparities, we talk about vaccine hesitancy. It is on top of the foundation of the structural racism, structural oppression that's occurring. And we know from this research, there are these secondary effects. We look at cardiovascular problems, we look at diabetes, and then the mental health issues of anxiety and depression that we see there. And we also see resiliency as well in looking at transgenerational resilience as well, because we know people are still here, I'm here, and so on. So it does mean that we have also communicated ways of coping, and those ways of coping need to be incorporated in the ways in which we provide outreach to these vulnerable communities. Now, I mentioned that has particular relevance to today's topic in looking at the COVID-19 vaccine. So one of the things that we talked a lot about last year in 2020 was about the infection rates and the disproportionate fatalities. A lot of that has to do with our predisposition when we arrive in these healthcare settings. And so it means that often, because of the experiences that we have and the outcomes, that we are physically manifesting the way in which we respond to structural racism. And it is seen in our bodies that when we arrive, we are often compromised. Our bodies are often compromised. And that certainly leaves us there, but it's also behavioral. So there have been some studies where we can take a look at the ways in which healthcare providers have not provided sufficient demonstration of cultural competence. So a lot of times they are misdiagnosing, they are not taking people seriously when they come into these healthcare settings. And so a lot of times it was overlooked. Then we take a look at policy. Initially, when we were just beginning to understand what was happening, when we were just beginning to understand the pandemic and how large this problem was, a lot of the data was not coming in broken down by demographics. So we didn't even know. So, governments were not even collecting data to be able to look at the various cultural and ethnic groups so that we were knowledgeable about the disproportionality and we could intervene. So there are a lot of factors that influence how the infection has spread, and also the fatalities that are associated with it. And also the issue that we often talk about is vaccine hesitancy. Now, I'm very fortunate. I'm working with some of the pharmacy faculty at Xavier, and we received several NIH grants. The National Institutes of Health have funded some research around vaccine hesitancy, around cultural competency of healthcare providers in knowing how to talk to community residents about vaccine uptake. And so we are developing some of those materials now based upon some research that we are currently doing. We have increased our outreach to communities and also in providing services. Now, I have a demonstration site, and it is the Xavier University of Community Outreach Center. And we created in April last year, we created the Reach Out Clinical Services. And this is a new program that we were offering primarily to the Gertown neighborhood residents whom we serve. And we wanted to help people by providing literacy about COVID-19 so that people knew what it is that they could do, what behavioral interventions that they could implement on their own in their families, in their communities, in their everyday workaday lives to be able to do that. We are also now incorporating vaccine literacy, COVID-19 vaccine literacy. So we are beginning to talk more and providing more information in the services that we provide. We're also aware that when we take a look at some of the cultural characteristics of the people in New Orleans in general, and African Americans specifically, we know that social isolation may disproportionately impact this community because we are so sociocentric. So, we emphasize relationship. Relationship is so important to be able to do that. That's why we have so many festivals, for example. We also socialize around food. We socialize around religion. We socialize, before we do anything. It's important for us to make connections to people. And so social isolation has hit us particularly badly in our communities. And so that's why we wanted to reach out. So we make phone calls where our goal is to reach every single resident in the Gertown community. And we cycle through making phone calls, reaching out, asking people, how are they doing? We also provide formal counseling on a HIPAA compliant platform to be able to provide full 50-minute sessions, for example, virtually to people. So we've been doing that since last April, reaching out. Now, some of you may already know that suicides have increased during the pandemic. It has particularly hit Black and Brown youth, and I think we're not talking enough about that. There was a recent news article about youth out west, I think it was in Las Vegas, in the Las Vegas school system, where they had a huge number of children who were committing suicide, someone as young as 9. So this issue of social isolation is important, and we need to look at these vulnerable populations as part of this, to be able to say to members of that community, this is important. It is very important that you take a look at this, asking yourselves, what is the risk? Which of these two things is important to you? When we take a look at who is dying, we look at those numbers, but we break it down to see who is dying. So we need to get the information out that we don't want people to die, and that we do need to have faith in our healthcare providers, in our scientists, in our immunologists, in our public health people, to be able to go ahead and stop the spate that not only is related to COVID infection, but secondary effects like the depression, anxiety, and also use it as suicide prevention. Finally, I want to, of course, I can't talk about this issue of race-related stress and talking about structural racism as it relates to COVID-19 and the infection rates and the vaccine as well, without talking about ethical concerns. Anyone who is engaged in not only behavioral research, but other kinds of research, generally have to go through some kind of training to be able to make sure that they are ethical in their research protocols. This is primarily due to these unethical practices that we know historically have influenced the ways in which Black and Brown people have responded to the healthcare profession, to researchers, to science. Anyone can tell you about the Tuskegee syphilis experiment. So even people on the street can point to the Tuskegee experiment and say, hey, no, we're not interested. They're trying to kill us. And I've literally heard people say that. People have seen, because of the Hollywood movie that a lot of people saw about Henrietta Lacks, and about how her a gene was used without permission. And so many times there are these anecdotal stories in the community about not trusting researchers, not trusting healthcare professionals, and that the COVID vaccine is just another case in which people are being used or abused. And so what we want to do is increase literacy for people, increase trust, but that means that we need to do our work as well. And so we have been working with the Outreach Center to actually go out into communities. So I very much believe in that. Although I'm a researcher, I have also been a clinician. I've been in private practice and have developed programs in communities. And so we thought it was very important to be able to not only engage in the research, not only talk about these things and provide promotional information and announcements to people to increase literacy about COVID-19, but we also thought it was important to deal with the behavioral aspect, to deal with the mental health issues that have been impacting these vulnerable communities throughout 2020 by being able to do that. I encourage people to reach out to me if you want to know more about the Research Center, the kind of research that we do, or you want to know more about Reach Out Clinical Services because you would like to refer people to the services that we provide. Thank you.
Okay, thank you. Thank you very much. The next panelist that we will hear from is Dr. Charles Elaine Geary. Dr. Geary is an infectious disease physician and epidemiologist. He is also the Chief Innovation Officer at Access Health, Louisiana. Dr. Geary.
Thank you so very much. It is such an honor and pleasure to be here with all of y'all on this panel. I've been asked to provide kind of the scientific perspective on the vaccine. So I'm going to be just showing you a very brief outline of kind of how the vaccine works, and then moving into looking specifically about these viral variants and how the vaccine does affect these viral variants. I think it's very important for us to be updated and educated about these viral variants. They're not easy. As a epidemiologist and infectious diseases physician, and oftentimes call myself a virologist, it's even hard for me to kind of follow. But I think that, you know, in terms of health literacy, it's important for us to learn about them. So that's how I'm going to spend my time here for the next 10 or 15 minutes. So again, thank you guys so much for having me. So let's first talk about the vaccine and how the vaccine works. I think that if more people understood how the vaccine works and saw the folks who literally developed the vaccine, I think that there would be a greater acceptance of the vaccine with respect to addressing hesitancy. So this is how these mRNA vaccines work, and they're really fascinating. So this is the coronavirus right here, and it's notable for its, or identified by these spike proteins, right? And these spike proteins form a crown-like image around the virus, and that gives it its name of coronavirus because of this crown-like appearance. Now, you see that these spike proteins here, these are what stimulate the immune system. These are referred to as antigens. So you're going to hear me refer to these as the spike proteins. You're going to hear me refer to them as antigens, and this is what stimulates the immune system. Now, previous vaccines have worked where they would take an antigen like this and they would directly inject it into you so that you would stimulate an immune system. Those vaccines often took a very, very long time and required a lot of manufacturing processes to actually complete. This is why they start working on the influenza vaccine 9 to 10 months before influenza season, because it takes so long to produce the vaccine. And so scientists at the NIH had been working on creating a vaccine that was much more rapid to produce. And this is where this mRNA vaccine comes in. And so what they did is about January, the first or second week of January 2020, the actual entire genome of the virus was released to the scientific community. And of course, what was identified here specifically was the part of the genome that produced that spike protein, right? So this is what they did. So scientists at the NIH were actually able to take this genome, and they were able to code it and create a laboratory version of this genetic code called mRNA. mRNA is basically it stands for messenger RNA, and it basically takes genetic information from a DNA or an RNA if it's an RNA organism, which in this case it is, and it basically takes it and moves it over to the ribosome. And the ribosome is like the 3D printer of the body. And we'll get into that in a moment. So what the scientists at NIH did was essentially code for that spike protein and put it inside this lipid nanoparticle. This is the envelope or the delivery device. And the reason why they used this in particular was because they needed something that was going to fuse with the cell. And so what happens is that the vaccine gets introduced into your arm in the muscle and immediately is taken up by the cells of the muscle, right? And you can see here that this delivery device immediately fuses with the cell here, and it delivers the mRNA directly into the cell. And the mRNA immediately finds the ribosome. And like I said, the ribosome here is the 3D printer of the body. And if you think how remarkable this vaccine is, because what happens is that ribosome, it has, on this genetic code, it has exactly the code that is needed, so that ribosome creates a spike protein. And it's actually using your body's or cellular's own machinery and ingredients. It's really quite the most organic thing that you can find, right? What happens is that the mRNA gets introduced into the body, immediately finds the ribosome kicks out that spike protein, and this mRNA, boom, vanishes. It's like the Snapchat of genetic material. It goes away immediately, and you'll see that it never actually gets into the cellular nucleus. So you hear people say, well, I'm afraid that this vaccine is going to affect my DNA. That's just not the case whatsoever, because this mRNA never even gets into the cellular nucleus. There's no mechanism, there's no way for it to get in there. So what happens is that that spike protein gets produced, and then it gets pushed to the surface of the cell. And once it gets pushed to the surface of the cell, it's introduced into the bloodstream. And then what happens is that the immune system responds to it. I'm sorry, sorry, I'm going to close my window. There's a lot of road work happening. I'm sorry, hang on one sec. My apologies for that. So what happens here is that this vaccine produces not only the antigen, but then also produces the immune response to that antigen. And here you can see these are antibodies that get produced so that if the virus is ever seen again, or if the spike protein, sorry, I'm hearing an echo. Okay, so that if this spike protein is ever seen again in the form of the virus, you will already have antibodies that produce it. So what makes this vaccine so remarkable? One is it could be produced in such a rapid period of time. And a lot of people talk about, well, this vaccine was created so fast, I don't trust it. Well, the reason why this vaccine was created so rapidly was because, one, we were in the middle of an epidemic, right? And so there were a lot of people who are already affected by the virus, as opposed to like something like HPV vaccine or shingles, which may take anywhere between 10 to 15 years to find the ultimate end goal, which is whether or not somebody got the vaccine and then developed HPV or developed shingles. Here, there was unlimited resources. There was an active epidemic happening right away, and they were able to create that vaccine in really a record time because of the resources, and because we were in the middle of an epidemic. They were able to find people to vaccinate, and they studied about 75,000 people, and there's been an incredible safety profile. I think here in the U.S. we've already vaccinated 25 million people, and the CDC has relegated this vaccine very, very safe. So again, what's remarkable about this vaccine is that we produce our own antigen, and then that antigen then produces the antibodies for it, so that if you ever see this spike protein ever again, it'll be in the form of the virus, and it'll have 95% efficacy. And I'll show you that again. But I think the most important thing is that I think we need to meet the originator of this vaccine. She first started at the NIH when she was 29 years old. You can see now here she says that she's 34. She's actually 35 because her birthday was just a couple of days ago. So happy birthday, Dr. Corbet. I do refer to her as the newest American hero, as she was the one that 29 came to the NIH with this information of how to create an mRNA vaccine. She was already working on coronaviruses when the outbreak happened. So she was really ideally placed to be able to lead the research with respect to creating this vaccine. And she's incredibly humble, as you can see from this quote that I love to read. It says, "To be living in this moment where I have the opportunity to work on something that has eminent global importance, it's just a surreal moment for me." And so I just want everybody to see and know who Dr. Corbet is, as I think she's a remarkable person in her story and her advancements to science and to really saving millions of lives is really remarkable. So just real quickly, talking about the vaccines have shown, this is looking at AstraZeneca, the vaccines have shown really excellent efficacy. When we look at the AstraZeneca vaccine, it shows about 70% efficacy. If we look at the Moderna and Pfizer vaccines, you can see here, this is the vaccine. These are the people, placebo, these are the folks that got sick. Again, this shows about 95% efficacy. What does that mean? That means that about, if you were exposed to the if you're exposed to the virus after you've been vaccinated with the 2 vaccines, according to the time scale that's been recommended, 21 days for Pfizer and 28-day period with the Moderna vaccine, you will have a 95% chance of fighting off that infection. What's not known is whether or not you still transmit the virus. I would argue that you still probably can transmit virus, probably for a couple days, and it is recommended that we continue to wear masks moving forward. So I'm going to spend the next 5 minutes or so talking about these viral variants. And there's a couple things that we need to understand right off the bat. So viruses change through mutations. That's just part of what viruses do. Sometimes new variants emerge and disappear, and other times new variants emerge and persist. And I think what we're seeing right now globally is multiple variants are all emerging, and they're all kind of emerging into and creating the same mutation, which we'll refer to as the B117. These mutations are very awkwardly named, so I'm sorry that I'm going to be using names that are going to be hard to kind of latch onto, but because B117 doesn't mean anything. But they all seem to be reaching the B117 final mutation, and I'll explain that in a moment. But the way that they're getting there is a little bit different per variant, and some of those mutations that they are accumulating along the way can be somewhat problematic, and we are going to talk about that in a moment. So this has become such an issue that the WHO held a day-long virtual meeting with almost 2,000 experts from 124 countries just to talk about viral variants. And they did prioritize diagnostics, treatments, as well as vaccines, or new updates for their vaccines moving forward. So very quickly, these are the big ones that we talk about. It is not appropriate to talk about it as the UK variant, South African variant, or the Brazilian variant, just like we probably wouldn't want one that emerged out of New Orleans being called the New Orleans variant. But because these are very awkwardly named, I will try to refer to them as their scientific names, but I put the table up here for you to see them. And so essentially this B117 that I'm going to talk about here in a moment is incredibly infectious. And I'm going to show you how infectious it is here. This is the one that emerged out of the UK. What we're looking at here is a week-to-week evaluation of the virus in the UK. Here in week 44, it emerged out of Leeds, England. And you can see a week later, it got a little bit more, a little bit more, a little bit more the week after. And then within 6 weeks, it became the predominant strain. And so you can see how fast this viral variant moves through populations. It's about 50 to 70% more infectious and likely to transmit. And this variant is the variant that we are now seeing likely in Los Angeles. And we have seen 2 specimens of it here in Orleans Parish as well. The CDC has predicted that this is going to be very likely to be the dominant strain starting in March. And here's some modeling that they did where this is the wild type virus. This is the virus that's circulating right now. And as the B117 virus increases, it pushes out the wild type of virus right here. And you can see this is in an unvaccinated population. And with a vaccinated population, it hopefully gets a little bit better. Now, the good news is that it does appear that the B117 viral variant that emerged out of the UK is likely responsive to the vaccines. Now, that now brings us to the 501YV2 variant that emerged out of South Africa and appears to also be emerging out of Brazil. And the first data that emerged from this, what we are seeing is that unfortunately this variant appears to weaken neutralizing antibodies. Now we know that it weakens neutralizing antibodies for those that had a natural infection to COVID. So in other words, your antibodies were generated because you were naturally infected with COVID. But what is not yet known and what was just released over the last couple of days is what happens when you have an immunization, if you are immunized. So the Pfizer preliminary data that was just released just a couple days ago. Preliminary data does show the Pfizer vaccine likely protects against the viral variant, the 501, which is again emerged out of South Africa. But unfortunately, antibodies generated from the Pfizer vaccine while they did protect against B117, they did not look specifically at a very, very specific mutation that we haven't talked about yet called 484. But just looking again at these Pfizer vaccines, the Pfizer and Moderna vaccine does appear to work with B117, which is very, very good news. Just yesterday, this study dropped, and which looked at, again, the 501v2 South Africa variant. And what it showed was that the Moderna and Pfizer vaccines do have some protective effect, but it does appear that this variant does affect the antibodies by about a factor of 6 or so. In other words, decreasing the strength of the vaccine, which the authors are now concluding that there may need to be updated vaccines in the future, which is something that we've been talking about recently with respect to, are we going to need a regular updated vaccine? It does appear right now that the data is preliminary, but it does appear that may necessarily be the case. So in summary, with these variants, I just want to say the B117 is a more infectious variant. The mRNA vaccines are likely protective against this B117 variants. This 501v2 that is common in South Africa and Brazil are more infectious. They disproportionately affect a younger population. We didn't really have time to talk about that. We also didn't talk about that there's an increase in viral load that may portend to more severe symptoms. These two things are being watched very, very carefully. Still, that's preliminary data is still needed to be evaluated. There's a decrease in efficacy of neutralizing antibodies, which we showed, but more than anything else, more data is needed, but it's actively being studied right now. And with that, I just want to say thank you so much for giving me the opportunity to speak to you all. It was very kind.
Thank you, Dr. Geary. Hello, everyone. I'm Carrie Mulder. I'm the Marketing and Communications Specialist for the School of Social Work, and I support Dr. Hayes and Dr. Perquet in putting on these HealthSpot events. I am elated to introduce our next panelist. It's Doc Griggs. He is a New Orleans-based community medicine director and health educator who has dedicated his professional life to raising health and wellness awareness in the New Orleans community and beyond. So welcome, Doc Griggs. Thank you.
Hi, thank you. And thank you all for allowing me to be here. Let me not cut my head off. Even though I cut my hair off, don't want to cut my head off. It's a pleasure to be here to talk to you about such an important topic. This is par for the course for Dr. Geary and I'm my colleague that just presented. We have done the equivalent of over 400 to 500 different shows and presentations. We have a podcast called the Noise Filter Podcast. It's 10 minutes of high yield information through a social justice and health equity lens, basically weeding through the madness of COVID-19. This thing dropped on us, and before I start, at the very beginning of this, I realized that anxieties were going up in the community. I pride myself on being a community medicine doctor and health literacy expert, meaning that I have my finger on the pulse of the community. So if you would go to Noise Filter Podcast, it's on all the platforms, Spotify and Apple iTunes, you name it, it's there. And you can check us out daily. We also have a daily cast that we do on Facebook Live, addressing the most current issues of the day. When I say we have been immersed in this 24 hours a day, we really have, to the point that my family calls my man cave the situation room, because it's COVID, it's going down. So I want everyone to take a minute to take a deep breath. We've heard a lot of information. Anxiety is high. We heard it earlier, is referred to as a triple pandemic. So I want everyone to take a deep breath. Take one deep breath in. Hold it, now breathe out. Now do it again, breathe in. Now breathe out. Now this time I want you to breathe in and I want you to smile. Breathe in. Smile. Now breathe it all out. My platform prior to COVID, and it still is get check, get fit, get moving, but we added a piece to it called breathe, check, step back. What I'm going to be talking about is the community impact of everything that's taken place. And that's something that Dr. Geary and I have trying to take in the mantle of between at the very beginning, going from church to church and telling anyone who would listen, like Chicken Little, that the sky is about to fall in person, to pivoting to virtual platforms, to radio shows, you name it. And there was a lot of mis and disinformation. We're talking specifically now about vaccines, and there was a CNN analysis that just came out, and Doc, you would be proud of me because I normally don't use props or reading material, but there was a CNN analysis of data from 14 states that found that vaccine coverage right now is twice as high among whites on average than it is among Blacks and Latinx Americans. Even though that Black and Latinx Americans are dying of COVID-19 at a rate of 3 times of what white people, and being hospitalized at a rate of 4 times higher, according to the CDC. We're fighting a lot with this vaccine. Dr. Geary very eloquently put the science together of how the vaccine works. Basically, what I like to tell people, it's the equivalent of when I was growing up with my grandmother, the new vaccines, the Pfizer and the Moderna, that's messenger RNA. If you can pretend that you can see little Eric in the kitchen on a Sunday with his finger in the pots saying, "Mom, what are we eating for dinner?" Getting hit with a spoon, don't eat that. And grandmother saying, "Go see what your daddy wants for dinner." I go to the living room, "Dad, what do you want for dinner?" He gives me the message or the recipe. He wants pot roast, green beans, and potatoes. I run back to the kitchen, which is the ribosome that Dr. Geary referred to. I give that information to my grandmother, and she serves the meal. That's basically the exact thing that's happening. Messenger RNA takes the genetic code for the red spikes, as you saw earlier, takes it into the cell. It goes into the kitchen where grandma is, or the ribosome. She cooks up the pot and starts whipping out the red spikes or the pot roast, green beans and potatoes that granddaddy wanted. And it goes out into the body, and we create an antibody response. Now, if you can imagine that as the premise for a vaccine response, if that's not good enough, if you can imagine being in the 6th or 7th grade and a bully says he wants to beat you up, and you take his picture and you send it around to all his friends and say, "If you see this guy's trying to hurt me," and they see him walking around the corner, and the friends come and they grab him and they immobilize him to the point that he can't hurt you. That's vaccine. It's basic science and basic understanding. Now, the premise of community medicine and health literacy that I practice is that it's based on the sender message receiver equation. We're used to being in formats where we can lecture people and tell people what it is that they need to do, and we want them to listen. That's typically been the healthcare model up until COVID-19 and the Band-Aid was ripped off. If you remember, we were telling people, "You need to get inside, need to get inside, need to get inside." And they're like, "I'm not moving until you tell me why. And until you answer my questions, and I understand it." In the sender message receiver equation, when dealing with the community and taking the complex things that we pay a lot of money to learn and try to give back in order to help us in a public health setting, we forget the most important component of it. There's sender, there's a message in the receiver, but there's also a feedback arrow. It's an arrow with two arrows on each, a line with 2 arrows on each side, meaning there's dialogue, question, and answer. The purpose of the interaction is to come to a mutual understanding. You might not agree, I might not want to go in the house, but you told me that there's a wolf loose in the neighborhood and we don't know where it is, called COVID-19. Oh, okay. Or is it like the German Shepherd that we have that normally comes inside when we call for it, meaning a coronavirus, or like the cat that just runs around and it sleeps all day and comes out at night? That would be the flu. No, it's not anything like that. It's wild. We have no idea of its behavior. So we need to get you inside. Now, once you understand that, you've acknowledged my questions, it shows respect, and I'll respect you and I'll respect your wishes. What we do every day with COVID-19 and what I try to do in the community, what I do every day on Fox 8 is I try to give the information to people so they can give it back to me and respect the fact that we can learn from them. The Tuskegee experiment, the Henrietta Lacks, those things being acknowledged, and then having real, hard, true conversations about them in the public, in the community, with the community, and being most honest. At the very beginning of this, we said, if you run into a doctor, Dr. Geary and I said, if you run into a doctor that is not willing to tell you, I don't know, find another doctor, or better yet, just run away from him. Be polite. Yes. All right. So yeah, okay. Just never talk to that person again because we don't know. We've been finding out things as they happen at the very beginning. If you remember, they were saying there was confusing messaging about wearing masks. And finally it came out that we all have to wear a mask. And now potentially we could double mask. It was really confusing. But being on one accord with the messaging like we're doing now, letting you know that everyone should get vaccinated when they get the opportunity to, letting you know that the vaccine is safe. I love the illustration every time Dr. Derek does it and shows that the messenger RNA, as we said, it goes to the ribosome or the kitchen. It doesn't even go to the main room of the house. It goes, or like the nucleus. It doesn't go near your DNA. It turns your body into a red spike factory, and it's safe. And what's interesting, even though we have the stats that we're saying, it needs to be acknowledged. You know, they put out data and say that, you know, that whites are being vaccinated at 2 times the rates of other races and da da da. But what they don't tell you is that it's incomplete data because we're not getting the demographic reporting from all states, which is something that Governor Edwards and Dr. Cantor demanded last week. At the very bottom line, understand that this is when you explain and you're in the community, understand it is safe. We've done it. Dr. Derry, we've taken it before. Our healthcare providers have taken it before. And the beauty is, you know, we're finding that people are really asking for the vaccine. There was a lot of pushback before, and now a lot of people are asking for it. And it's let me see you go first. And now that people are seeing that that people are surviving the vaccine, they're willing to take the leap and be safe because we're all trying to get to the same end. I want to make sure that we have time for questions. Just understand when you hear about negative things happening in the media, in the news, or on social media, remember, those are newsworthy things. There have been millions upon millions of people that have been vaccinated at this point. There he is. There he is. Is that Elvis? There have been millions of people that have been vaccinated. And when you see an incident, an isolated incident, 1 or 2 people that might have an adverse event, it doesn't change the nature of the safety of the vaccine. This was not rushed. It had been worked on for decades. And because there were so many resources, 75,000 people volunteered for the clinical trials for the Pfizer and Moderna vaccine. That never happens. They had unlimited financial resources to get this because the entire world is trying to get back to normal. So understand, look through it through a lens of scrutiny, look through it through a lens of trust. And now that we have a voice, science has a voice, we can rejoice. The $500,000 that we all paid for our education actually means something again. Pay attention and trust us. And if you have any questions, please feel free to ask. Thank you. Awkward silence. Are there any questions that we might have?
Dr. Hayes, you're still on mute.
I'm sorry, guys.
That's all right.
Doc, we're going to take the questions at the end.
Okay.
Right now, we're going to introduce Dr. Andrea Anopoulos. Dr. Andrea Anopoulos is an associate professor and program director for the International Health and Development in the MPH program at Tulane University. Welcome, Dr. Andrea Anopoulos.
Thank you so much, Dr. Hayes, Dr. Parkhead, and Carrie for organizing this panel. And it's a pleasure to get to be part of this panel with such exciting presenters today. I'm participating today to represent the Tulane Home Team. That's the Homelessness Outreach Methods and Evaluation Team, which also includes some other people who I see on the call, faculty members Tanya Hansel and Mark Van Landingham, and other students who have been involved in this group that came together that represents social work, public health, and the School of Medicine at Tulane. Katie Campa, Denise Barrera, Naisha Ford, Laura Nguyen, Tony Critelli, and many, many others. And so our group came together at the beginning of when the COVID epidemic originated back in March of last year because we were particularly worried about how COVID would influence people who are experiencing homelessness and people who are unstably housed. And with an understanding that this population is particularly vulnerable to COVID. It's hard to follow stay-at-home orders when you don't have a home. It's hard for people living in encampments to follow guidelines about hand washing and other things when they don't have access to that. And we saw rapidly as COVID affected so many parts of our communities, the closure of public spaces like libraries, which even more limited access that people experiencing homelessness had to places where they could protect themselves. We were also really worried about the impact COVID could have on the very important organizations providing services to people who are homeless, and recognizing that these people who work there are often racial groups that are highly affected by the epidemic themselves, could be in older age, and are on the front line when they're trying to provide services to homeless people, but don't have some of the same protective resources that other healthcare providers are afforded. And so back in March, our group came together and decided that this was a really important event to document, and that we didn't really know how things were going to unfold with COVID. It was a crisis that we'd never seen before, and that one way that we could participate was by documenting the experience we saw these groups having, people who were homeless and the providers who were trying to serve them, and trying to understand their experience so that we could better inform services about COVID that were designed for them, including vaccination. So when we think about people who are homeless, the number of people are quite large. In the US overall, there are about 600,000 people who are homeless or unstably housed. And in the Orleans and Jefferson parishes, there are approximately 1,200 people who are homeless, at least according to the latest point in time count. COVID has impacted all aspects of this population, including our ability to count them. In fact, the annual point in time count was held just last week under drastically different circumstances with COVID, and really inhibiting our ability to get an accurate number of people experiencing homelessness, especially at a time when that population is growing with the economic crisis happening at the same time. Another thing that's very challenging about reaching this vulnerable population is that they aren't always visible, or it's very difficult to sometimes find what people would term literally homeless or unliterally homeless, people who are not in shelters or encampments, but might be sleeping in their cars or teetering on falling into homelessness and couch surfing. So there are a lot of vulnerable people that we can't see so easily. So what we did is we embarked on talking to organizations, providing services to these groups, doing in-depth interviews with them, participating in continuum of care meetings for homeless service providers, and interviewing people who are experiencing homeless as well. And we are about halfway through our data collection for this small qualitative study. And some of the things that we've learned is that organizations have responded swiftly to problems and opportunities and have faced difficult scenarios in very admirable ways, especially the many case managers and outreach workers we saw rapidly respond to needs as people were moved from encampments into hotels, and as people rearranged how they were providing services within those hotels, and moving people from hotel settings into permanent supportive housing, lobbying for the CARES Act, and really becoming involved in advocacy to help this population. Some places had to shut down or close during different points in the epidemic, including day shelters and other places, so that it became more difficult for homeless people to find food distribution places, to do their laundry. And like our first presenter mentioned, they began to experience more social isolation as these places not only provided needed services, but a way for other homeless people to come together in a social way. Shelters have had to work at lower capacity to provide shelter services and have faced challenges with their own staff being exposed to COVID, and also having to quarantine places within their shelter and move people into quarantine places established through hotels and other places by the government. In terms of vaccination, we know now that healthcare for the homeless is a system being equipped with vaccine, and they are going to start vaccinating people ages 70 and above in compliance with state guidelines, including those who are homeless. The city has contacted all the homeless medical providers to try and coordinate vaccination distribution. And they're going to try and build on the existing infrastructure for distributing hepatitis A vaccination to the homeless. One thing that is unclear is whether or not people working at organizations serving this population will be provided vaccination at an accelerated rate compared to other groups. And it's something that our group feels strongly should be considered. Some of the other things we've learned about vaccine hesitancy or uptake from the interviews that we've done is that there's really a mixed bag in terms of homeless people who said they would take the vaccine. And we've had as many no's as yeses in our small group. At the same time, we began asking people about this before the vaccine had come on the scene and was available. Expressions of hesitancy mostly related to trust in something that's brand new and wanting to wait and see if it works and how other people react to it. We asked people who should give it, and some suggested a distrust of government agencies in general, but the very good connections to homeless healthcare providers like the Healthcare for the Homeless organization. I think what this means is that as we reach early adopters with the mechanism of vaccine distribution through healthcare for the homeless, we might also need to consider vaccination distribution outside of clinical settings. Some people suggested that we consider shelters and other places as distribution points for the vaccine. They also mentioned that it's important to get information about the vaccine through word of mouth, not only through traditional measures, as not everybody has access to news or the internet, and this can be especially limiting in times when libraries and other places used by the homeless close. Overall, there was a heavy sense of stigma about being homeless expressed by the people that we've interviewed, and an emphasis on the fact that there's not one type of homeless person. This is even more true given the economic crisis that we're experiencing and that more people may become homeless as a result of it. People at our study expressed as much worry about the economy and how that would affect them and their housing as the health effects of COVID. So it's important that we keep all of the unintended consequences of COVID in mind. It's also important to remember that many homeless people work. They just don't have a livable wage that supports housing in a stable way for them. Several participants work in the food industry, which has been hit very hard by the crisis and by COVID. And it's important to consider that people experiencing homelessness are involved in our community, are an important part of our community, and an important part of the epidemic. And to highlight this point, I want to share and kind of close my presentation with the words of one of our participants who talked to us about his decision about vaccination and working in the food service industry. He said, "When it comes to priority, the homeless will be at the bottom of the road," which is funny because I'm in a homeless shelter and I literally work in like the #2 restaurant that feeds the upper crust of my city. You would think that someone like me in the restaurant industry would be tested like the hospitals, because the probability of me coming into contact with people is so much higher than a suburban family that lives in a big house and goes to their office and interact with 10 people in their board meeting. I'm interacting with 100 people every single day on average. I hope the project brings the vaccination or testing to shelters. It's the poorest of our population. And so as we think about marginalized populations, I hope we will consider ways that we can have special outreach programs for this important group. Thank you.
Thank you, Dr. Angelopoulos. I am going to ask all of our panelists to turn their cameras back on because we're at the Q&A portion of our session. Some of you may have already noticed that the questions that are going into the Q&A have been answered. Dr. Geary's answered quite a few of them, but you're welcome to put more questions there in the Q&A and we'll be going through them. But I wanted to catch some of them that have been put in the chat and then, see if there's any additional ones that come up. So the first one I'm going to kind of bring forward in the chat is, are there any differences in the Moderna and Pfizer vaccine, and is one given to a particular population?
No, there's no difference between the Moderna and the Pfizer vaccine. But I will say that the manufacturers of the Moderna vaccine which was the US, the NIH, like we talked about, Dr. Corbet, did name the vaccine in a way to remind all of you all that it is an mRNA vaccine, because Moderna has an M in it, and then it ends in the 3 letters RNA. So it was named purposely so as to remind people that it is an mRNA vaccine. The differences between the vaccines rather, is that the Pfizer vaccine needs to be kept at about minus 70 degrees Celsius. So it requires a very, very, very low temperature for storage, which was initially a difficult task, but a lot of the hospitals, certainly here in the area, as well as some clinics, did purchase those ultra low temperature freezers. It also requires a 21-day difference between your first vaccine and your second dose. The Moderna is a little bit more flexible. It can be kept in freezers of minus 20 degrees. So you'll find that in more is common that you'll find in pharmacies and hospitals across the city. That vaccine has a 28-day difference between the first dose and the second dose. Initially, what we're gonna probably see is that the vaccine for Pfizer is gonna probably be relegated for cities and city centers, whereas as we get more vaccine out into the more rural areas of the US, you're likely to see more of the Moderna vaccine because it is a little bit more forgivable than the Pfizer vaccine. And then lastly, next week we are going to get more information from the Johnson & Johnson vaccine. And if that ends up being a successful vaccine, that does not need to be frozen. And also it's a 1-dose vaccine. So I think that we'll be able to, so for particularly Dr. Andrianopoulos, I hope I got your name right, I'm so sorry. For some of the populations you were talking about, I think that the Johnson & Johnson vaccine would be very ideal for populations like yours that are a little bit, that are a bit more vulnerable. And getting them on the first time would be ideal.
Thank you. As sort of a follow-up to that, with the 2 vaccines, is will you be administered the same vaccine when you receive your vaccination shot? So you'll get, in the question is, if you've got the Moderna as your first, the second shot, it will also be Moderna, probably won't be Pfizer, correct?
100%.
Yeah.
100%. Because remember, if you get your first Moderna vaccine, so Doc Griggs and I showed you the image of us getting vaccinated live on television. We got ours, it was Moderna. So that's a 28-day difference. So we would have to wait 28 days, so 4 weeks essentially, before we get our second Moderna. It's not like we would wait 21 days and then go get a Pfizer vaccine. That would be, that's not the way that the studies were conducted. And I really strongly recommend that we stick within the structure of how the studies were conducted.
Great, thank you. Well, we're still on the sort of vaccine question. I'm going to grab this one from the Q&A, which is, do we know when the general population will be able to receive the vaccine? Right now, it's sort of essential personnel, 70 over, that sort of thing. But do we have any ideas?
So right now we're looking at late spring, early to late summer. Things are in flux because of supply chain. We know that there was the illusion of a reserve supply that turned out not to exist. So things have been ramped up to try to play catch up from the top down, from the federal level all the way down. So things are having to be adjusted. So typically by the summer, late spring to midsummer.
Yeah, I was going to say, as Doc Griggs said, I think that, initially, the analogy that I use is initially we saw that testing was very sparse and scarce initially, but then now there's kiosks where you can just go up and do your own test. So we're going to see something like that with the vaccine as well. It's going to be a moment while the new administration begins the process of basically kind of figuring out where things left off with the previous administration, how to create those logistical elements so that vaccines can get to states can get the vaccines distributed to city centers, hospitals, clinics, and that sort of stuff. So it's gonna take a while. Doc Griggs says late spring, early summer. I would say mid mid-spring to maybe, Doc Griggs thinks I'm being a little too optimistic.
Yeah, I do.
We often we've been changing roles back and forth. I'm usually the pessimistic one and he's the optimistic one.
Yeah.
I'm feeling a little bit more optimistic. I would say the general population, probably mid to late spring, possibly. I think you're right, Griggs. You're right.
Yeah.
It's going to be late spring, early summer. All right. You talk to me.
The message is to manage your expectations and understand since the very beginning, you've been seeing behind the curtain of what we do as researchers and scientists and doctors and all of us on this panel. We do this all the time. It's just, there's usually not cameras and microphones, and which makes things less forgiving. Things go immediately from the bench to preprint on Twitter, and it's kind of hard to compete. So just manage your expectations, understand that it's a scientific process and you'll get it when it's deemed most safe for you.
Awesome. Thank you both. I'm going to grab one of these questions from the Q&A section. Could you explain more about the E484K mutation? The person that put in the inquiry says they've read a bit of the blueprint paper, but is still kind of confused about how it will affect our situation going forward.
Right. I saw that and I'm glad that we're going to talk about it. Do you mind, Ms. Carey, if I share my screen again? Would that be okay? Great. All right. So it's a really good question. I knew that I glossed over it, so I'm going to go back to this table. The E484K mutation is super technical, and again, for those of you, I hope that you just kind of hang with me. I think that as Doc Griggs talks about regularly, and Doc Griggs and I broadcast and podcast daily, so I hear from him regularly about the importance of health literacy. So this is one of those health literacy things that I think that are important. I wouldn't spend the time talking about it if I didn't. So what happened was that each of these viruses essentially got to the same B117 change in spike protein, but the way they got there was separately. Okay, the analogy I use is that there may be 100 ways to get to grandma's house, right? So there are lots of different ways, but at the end, you get to grandma's house. And this analogy is the B117. And essentially, just let me mention what that does. That B117 changes the spike protein. So if this is the configuration of the spike protein, it shifts at 20 degrees. And just that shifting of that spike protein on the surface of the virus, it's like a key going into a lock. Imagine when you have a key fitting into a lock and it doesn't quite fit, you gotta kind of wiggle it in a little bit and then you get it in, it kind of sticks and you gotta open up and unlocks the key. The way it works now with this B117, imagine that key just whoop, sliding right in and opening up that lock much easier. So that's what that B117 does. Now, to get to that B117, each of these viral variants took a different route to get there. Now, it turns out that the route that the South African and Brazilian viruses took was a mutation at the spot called E484K. Okay, that ultimately led to that B117. And what that E484K mutation has been shown is that it is better at infecting, at becoming more infectious. It has been shown to infect a disproportionately younger group of individuals, so those that are under the age of 20. So we're seeing those people who have this E484K that they're infecting individuals under the age of 20. The 484K mutation, if you're infected with the 484K mutation, you have higher viral loads, and higher viral loads portend to more symptom severity. So that is somewhat problematic as well. And then lastly, we don't know yet, we just saw just a little bit of preliminary data that was released last night, but we don't know yet if the Moderna and Pfizer vaccines are effective against the 484K. We saw early data that showed that if you had natural immunity to COVID, so in other words, they went to somebody who had COVID antibodies, they took those antibodies out, and they exposed them to 484K viruses. And what happened was that the 484K viruses were able to deneutralize. They were able to attack those viruses by a 10-fold factor. Now, what happens when you see people who've been vaccinated with the Pfizer and Moderna vaccine is that we see that there's a 6-fold decrease in the efficacy of those antibodies, leading to potential annual updates of the vaccines. I'm going to turn it over to Doc Griggs because I know Doc Griggs is going to take some of my technical language and turn it into a little bit more user-friendly language.
Yeah, so I did a segment on it this morning on Fox. And basically what happens is, imagine there's a war and you have your troops. Well, all of a sudden the virus's troops have keys to get in the doors and windows of your house, whereas the original version just had keys to the doors. Well, now on the way to grandma's house being more effective, they picked up keys to get into more houses, more ways. And on top of that, they can decrease your soldiers, your antibodies to instead of 60, you have 10, or let's just say for easy numbers, it's a 6-fold decrease, but to make easy numbers, just say instead of 100 soldiers, you have 10. So they decrease their soldiers and they're able to bring more of theirs, and it's easier for the locks, easier for them to get in your house because they have the keys to the windows and the doors, if that makes sense. Now, the good thing with the studies that Doc was talking about is we don't know. Dr. Fauci even said at 4 this morning, whenever we were up watching it, he said that we know that the vaccines, Pfizer and Moderna, are both doing trials on booster shots. It looks like we might be taking a booster shot every year. We take booster shots for influenza every year to protect ourselves, but they're doing, and the fact that Dr. Kizzmekia Corbet came up with this technology means it won't take long to make tweaks to the vaccine. So right now you're covered, but what we noticed is even though they're covered, you're not quite as covered. And it's concerning because we don't have a lot of data and we don't know if it's how long that'll last or if it's consistent. So we have to go back to the scientific process to make sure. Now, the big thing about any of them being more infectious or more transmissible, B117 or he told me not to say South, not the one from South Africa, what is it, E484K is the fact that if it's more infectious, let's just say that nothing was different. They were all just more infectious. What would happen is what we're concerned about is the hospital systems being overwhelmed. More people would become infected, more positives eventually lead to more hospitalizations, which ultimately lead to the last lagging indicator, which is death. And if you look at 2 weeks, then 4 weeks, you see it. That's what we've noticed all the way through this. So the big thing is not to panic. Doc is an infectious disease doctor. So whatever he does, I do. Once he started double masking, I started double masking. If he chews gum, I chew gum. If he doesn't comb his hair, well, I can't do that. But wearing a double mask, it's not a CDC recommendation, but Dr. Fauci and other doctors in the field are saying that they personally double mask just to protect themselves. If we can double down, and Doc, real quick, if you can talk about that change to the CDC recommendation about the washing hands and the congregating. It's congregating.
Before I do that, why don't you talk about the Swiss cheese model in light of what you're talking about double masking?
Yeah, so the point of the double masking is creating more of a barrier of protection. Understand that the vaccine is not the magic bullet, nor is the mask, nor is any of the other recommendations. It's all something to put in your tool bag. So if you have a mask and it has holes that go this way, and you put another mask on this way, you cover more surface area to protect you from breathing out respiratory droplets or breathing in respiratory droplets of other people. So if you have layers and layers of Swiss cheese, eventually you'll have a block that'll be impermeable. And that's the concept of wearing the double mask.
Absolutely. And just to kind of wrap up on what Doc Griggs was saying, I was just going to share my screen one more time here. Doc Griggs was asking me about this infographic. I showed you this slide. I meant to show you this infographic and I forgot to do it. This is the new messaging from the CDC that came with this B117 article they released last week. But look what they did. They say, wear a mask now, stay at least 6 feet apart, avoid crowds, and get vaccinated when you can. And what's missing now? What used to be here? What used to be here was hand washing. And they replaced hand washing with avoid crowds. And to me, that signals that that finally we're moving away from this idea of hand hygiene being important. Now, I'm an infectious disease doctor. Hand hygiene is massively important to me. So I love it.
I'm not infectious disease, but I'm my grandmother's child. Wash your nasty hands. Wash your hands. Keep washing your hands. Please wash your hands.
So important. But in terms of coronavirus protection, we know that the surfaces and fomites or what have you, there's just no evidence of transmission in that manner. So, but avoiding crowds. So double masking for me, double masking. I don't go anywhere where there's people unless I'm going to the grocery store or if I have to make quick errands. But avoiding crowds is super important as well.
It's big. Even in spite of the coronavirus fatigue that was alluded to earlier, we're all tired, but we got to do our part.
Awesome. Thank you all. Oh, Dr. Olatunji, did you want to say something? You unmuted.
Add just long-term things. So because I want to add to the behavioral aspect of this and our mental health. So one is that the vaccine is not a cure-all. So the idea is that you need to keep doing these things anyway. And also in thinking about what I've read about the 21st century, that it's going to be all about coronaviruses. And so the sooner we get into behavioral changes, lifestyle changes in terms of that, and also about stabilizing, because again, we've had these such extreme experiences not being able to be with other humans. And we are wired to be relational. We are wired to be social and with other people. And so I can't emphasize enough this idea of social isolation and the impact that it's having. And I know we don't talk a lot about the mental health aspect of it, but it is huge. It's a huge part of this. So we can't talk about interventions from the therapeutics or doing prevention or any of that without thinking about personal agency. So we all have to ask ourselves, what is it that I can do to minimize the impact of this? How can I change the way in which I live so that I am not experiencing these severe kinds of responses to coronavirus? The vaccine is not the cure-all to it, but it's certainly a huge help to us to save lives.
Thank you. Dr. Hayes, I saw you pop on. Did you want to raise something? No, you're just hanging out. Okay, great. I wanted to, we don't have a ton of time left, but and this question was answered in the Q&A, but I think it's an important component of this conversation. And it's about Dr. Corbet and her role in developing this vaccine. And, the question was, would more sort of PR about Dr. Corbet's role in developing the vaccine help with vaccine hesitancy for populations of color, seeing that the scientist behind it is a person of color, and Dr. Geary responded, Dr. Olatunji responded, but I think I would love to sort of have that conversation verbally as well for our participants and attendees. I don't know, Dr. Olatunji, if you and Dr. Geary, if you want to just say what you wrote in the chat, just sort of opening it up.
Well, I'll defer to Dr. Olatunji to start.
Well, I responded, and someone asked whether or not it's important to have Dr. Corbett in to get videos and to present her and so on. But it's Dr. Corbett and all of the other people who are doing this work. The idea is that we need to increase credibility and trust within these communities. And so we really do need to challenge healthcare professionals and healthcare institutions to realize that they have a lot of work to do. They have catch-up work. And that they need to take responsibility for our current circumstances and not blame the victim. Sometimes that's out there, not everybody does that, but that positioning is out there. And so we need to do a lot of work to re-educate people so that they know how to reach out to these communities because trust is an issue. How do you establish trust? Well, one is, and you've heard it here today in so many different ways, explicitly and implicitly, about telling the truth and being transparent. is important. So you heard Dr. Griggs say, hey, we need to have healthcare professionals who say, I don't know. That increases trust. So that is evidence-based, that's based on our research, and we understand that in terms of human nature. You become more trustworthy when you say, I don't know, not less so, more so. So it's important to be able to do that. It's important to get training to understand how to work with vulnerable populations and to know people are not being aggressive, they're not angry Black people, brown people because they're asking questions, but it's because they are aware that there have been these ways in which people have disrespected members of their community. And so we have to start the conversation there with that understanding that people may be hesitant, may be anxious, may lack trust in what it is that healthcare professionals and institutions want to do. And so we need to start there and be honest. I love the idea of even having conversations about that. I know that people of color talk amongst themselves about this, but that conversation needs to be much more explicit and part of our professional training. We need to know and be comfortable with having these courageous conversations where we talk about how people of color have experienced healthcare over time. So we need to have that conversation, but most importantly, we need to be able to include all of these wonderful healthcare professionals of color in particular, and be able to have them to come into communities, to have them to develop social media that is directed toward vulnerable populations, to be able to get videos, to have more of these webinars. So we need lots of ways in which we need to get these voices out there. So Dr. Corbett is, is amazing, this young woman. I saw her way back in March and April of last year, and looked her up and looked up her work and so on. And it really guides us in terms of the funded work that we're doing now. But she is only one of many epidemiologists, immunologists, psychoneuroimmunologists, the people who are connecting behavioral health to immunology to be able to do that. So there are lots of professionals out there, and we can tap them. We can tap them. There are lots of Dr. Griggs out there. So we need to find them and we need to bring them and introduce them so that we can have these informal conversations in these communities so that we can reduce the anxiety and increase the trust.
And just a quick small pearl just to add to that. Before there was a Dr. Kizzmekia Corbett, in 1721, there was a slave called Onesimus. He was a slave. He was owned by Cotton Mather in Boston, Massachusetts. And he introduced the whole concept of vaccines. He called it variolation. There was a smallpox outbreak. Cotton Mather asked his slave what he did with smallpox in Africa. And he said they used the pus to help vaccinate or inoculate people to protect them against it. Then here, 100 years later, Edward Jenner took the process of cows. If you're vacca in Latin means cow, took that same process with cowpox, because they didn't want to tell people they're giving cowpox, and called it vaccination. So it started with a person of color here in the United States. And just to throw that pearl in, all the studies show that we're trusting of people that we see, and sadly, only 2.9% of the doctors that you see look like me going into the community. So if you give that pearl and the foundation to give people a little ownership in it, and then bring it up to Dr. Corbett, and then have these frank, honest conversations, you'll find the trust increases magnanimously.
Yeah, in education, we call that scaffolding. You take people from where they are and take them to where you want to go. So you create a bridge in that way. And so, yeah, that works extremely well. So that's an excellent pearl to offer to people of one thing you can do today to use right after this webinar. It's something you can do different to have better outcomes. Absolutely.
Wonderful. Thank you all. Thank you all so much. I think we've just got a few more minutes of our time. Dr. Hayes, did you want to? Yeah, there we go.
Hi, guys.
She has such a beautiful way of closing these things out. Don't trust, if we're talking about trust, I should not be trusted with that duty.
No.
I'm going to defer to Dr. Hayes to close us out.
Thank you, Carrie. I really appreciate Carrie so much because she helps me with all the technical stuff that I do not know. But I just am so excited about today's webinar. The purpose of this webinar is to give you tools to take back to the community so that when you work with your clients and your client base, you can give this information in a way that is knowledgeable and that will create trust in the process. So we really appreciate Dr. Olatunji, Dr. Geary, Dr. Griggs, and Dr. Andrianopoulos. We appreciate all of your knowledge, all of your skills. This webinar will be available to you on YouTube. You will be able to have access to it. You will receive an evaluation that we will ask you to complete. And in that evaluation, there's a question about future webinars that you would like to see. We do these every other month. So the next one will be in March. We might do a little special one for Black History. We have to see what we come up with, but usually they're every other month. And we have people in our community who are experts in subject matter that are willing to provide you with the information. So we really hope that you sign up again. Thank you so much, and please fill out your evaluation. We appreciate you. Dr. Parquet, any closing words? I think he's there.
I just want to say thank you again to all of our panelists for providing such valuable information and informative information to our community. And it's because of people like you all that we're going to actually defeat this virus. And we certainly want everybody who participated in this seminar to, as Dee said, to take this information and to share it with everyone that you come in contact with. And we certainly look forward to future presentations, and we will certainly have these panelists back on in the future again. And I just want to say thank you all so very much.
Okay, well, thanks, guys. For social workers, you get 1.5 CEUs. So please send your evaluation back to Carrie to get your certificate. And once again, thank you.
Thank you for inviting us.
Bye-bye.
Yeah.
Thank you.